Hey everybody, my name is Chase Ballard. I'm sorry I'm just now getting around to submitting my video case study. I confused a deadline with my other class. So I do apologize for the late submission, and I do hope that some of you guys still get to see this. I do have a paper here I'm going to follow, so I may look down quite often, but I hope you guys learned something. The patient I will be talking about today is RL. He is a 68-year-old male who is retired and is currently married to his wife of 42 years. He was recommended to my facility for possible ventricular assist device or VAD placement from an outside facility. He has a history of coronary artery disease, chronic kidney disease, diabetes, COPD, emphysema, cardiac stents, mitral valve regurg with a mitral valve replacement, and a 32-year history of left lower extremity osteomyelitis related to a motor vehicle accident in his early 30s. He is currently on chronic antibiotics for his osteomyelitis. The consulting cardiologist at my facility explained the risks and benefits of VAD placement in regard to his osteomyelitis, and that placing a foreign object like the VAD into his body would place him at an increased risk of infection. The cardiologist would only agree to perform the procedure if the patient agreed to a left below-the-knee amputation. The patient declined to the removal of his left lower leg, and his condition has since worsened. I presumed care of this patient well into his third week at my hospital. Since admission to the hospital, his condition has very much deteriorated. He had a 4-vessel CABG about a week ago, and his EF has been determined to be 15 to 20% from a previous echo. He was also cannulated with a right subclavian impella device a day after his CABG. The patient is currently mechanically ventilated and requiring hemodynamic pressor support. The patient has a Swan-Ganz catheter to his left IJ, along with bilateral radial arterial lines, a 20-gauge IV in his left hand, a 20-gauge IV in his right hand, and an 18-gauge IV in his left AC. The physical exam of the patient revealed the following. The patient is lightly sedated on 0.5 mics of Precedex and opens his eyes to speech. The patient can shake his head yes or no to questions and follows verbal commands. The patient can move all extremities weakly. Pupils are sluggish but reactive, around a 3. The patient is having continuous bloody drainage noted in his nasal and oral cavities, along with blood-tinged ET tube secretions via inline suctioning. The patient is in sinus rhythm in the 80s with rare PVCs noted. Upon auscultation of heart sounds, S1 and S2 are present, along with the mechanical sound of the impella device. The patient's bilateral upper extremity pulses are normal at a 2+, and his bilateral lower extremity pulses are weak and confirmed by a Doppler. Upon auscultation of anterior and lateral lung sounds, they are clear and diminish. The patient's bowel sounds are hyperactive, and the patient has had 2 liquid bowel movements per the previous shift RN and report. During my skin assessment, there is a mid-sternal incision noted along with 4 chest tube exits, all which are covered with occlusive dressings at this time, with no signs and symptoms of bleeding or drainage noted. The impella site is also covered with an occlusive dressing with no signs and symptoms of bleeding or drainage either. The patient has generalized bruising bilaterally. The patient has reddened heels and a reddened gluteus to which a protective Mepilex foam dressing is applied at this time. The patient also has a draining wound to his left lower extremity that is currently draining purulent drainage. Most of the past medical history has been mentioned above. However, the patient does have a maternal and paternal history of heart disease and diabetes. The patient takes 10 milligrams of oxycodone BID for chronic back pain and Kefsol for osteomyelitis at home, confirmed by his wife at bedside. This patient's medical diagnosis is so diverse, so for the sake of this assignment, I have decided to explain the pathophysiology of coronary artery disease. According to our textbook, coronary artery disease occurs when atherosclerosis occurs in artery and vessel walls. Atherosclerosis is a chronic inflammatory disease characterized by thickening and hardening of the arterial wall. Lesions or plaques composed of lipids develop on the vessel wall and calcify over time. Development of these lesions causes vessel obstruction, platelet aggregation, and vasoconstriction. In coronary artery disease, blood flow temporarily diminishes in the coronary arteries, causing oxygen reduction to the cardiac muscle. Decreased blood flow may or may not cause permanent damage to the myocardium or cause infarction. Contributing factors to coronary artery disease are diabetes, stress, hypertension, and tobacco use. According to our textbook, despite great advancements in treatment, cardiovascular disease remains the leading cause of death in the United States. The book also states that coronary artery disease is a leading cause of myocardial infarction per a statement from the CDC. In addition to causing MIs, coronary artery disease can also cause heart failure, dysrhythmias, and sudden death. Clinical manifestations of coronary artery disease include the following: angina that can radiate to other locations, for example, your jaw, neck, arm, or back, indigestion-like sensations, nausea and vomiting, cool, clammy extremities, diaphoresis, and fatigue. There are numerous diagnostic tests and treatment options for coronary artery disease since it can be so diverse. According to our textbook, most diagnostic procedures involve identifying contributing factors, for example, a lipid profile, angiography, and nuclear imaging. Additionally, a history and physical examination, exercise stress test, echocardiogram, and EKG. The textbook also states that treatment focuses on preventing MI by reducing modifiable risk factors through the same strategies used to treat dyslipidemia and atherosclerosis, such as dietary changes, tobacco cessation, physical activity, weight reduction, stress reduction, diabetes management, hypertension control, angioplasty, bypass procedures, laser procedures, antiplatelet agents, anticoagulants, thrombolytics, and lipid-lowering medications. Some common medications that may be used for coronary artery disease, according to our textbook, are nitrates, beta blockers, and calcium channel blockers to vasodilate the coronary arteries and increase the oxygen supply. Since the case of this patient is very intense, I found 2 research articles supporting the treatment option he was being given at my hospital. According to Pepino et al., patients undergoing coronary surgery have changed in the last years, becoming a challenge for the cardiac surgeon not only for the quality of the coronary artery involved, but mainly for the quality of patients in terms of low ejection fraction. The recently developed Impella device presents a compromise between circulatory support and limited invasiveness. In this study, the myocardial revascularization was performed using complete arterial revascularization. The Impella device was left in for 48 hours after the operation. In this study, all patients were discharged home after 9 to 10 days from admission, and a follow-up echo performed 6 months to up to a year after the operation showed an increase of the EF up to 40 to 45%. In conclusion, the use of the Impella device for patients undergoing off-pump CABG is feasible and safe and appears a promising strategy to improve both short and long-term outcomes. The most appropriate treatment option for this patient is VAD placement. However, the cardiac surgeon did not consent to perform the procedure with the patient's current left lower extremity infection. According to Patino and Calpe, patients who require left ventricular assist device or LVAD placement frequently either have had previous cardiac surgery or require future sternotomy. As a result, these thoracic surgeons have explored approaches to avoid sternotomies. Their group has had success with robotic-assisted left mini anterior thoracotomy placement of LVADs. This approach has the advantage of allowing the graft to lie in an anatomic location while avoiding the morbidity associated with a median sternotomy. However, despite their clinical advances, these are not offered at my hospital, and the risk of placing a foreign device in the heart with a present osteomyelitis infection still place the patient at increasing risk of developing an infection or septicemia. Lastly, I will discuss the patient's outcome and the impact on my current nursing practice. My patient is still currently on my unit and has had the Impella device placed well over the recommended time frame. He is eventually going to have to agree to have his left lower extremity amputation, or there is no chance he will be able to live through this admission. There is not currently a specific discharge plan. Of course, we hope all of our patients make it back home with the best quality of life possible. However, this patient will have a very long recovery. The patient is being seen by respiratory therapy, physical therapy, and occupational therapy. I have become extremely attached caring for this patient. His family is always pleasant. However, they do not understand the severity of his condition. Moving on, I will attempt to educate both the patient and his family on his disease process and the risks and benefits of continuing the Impella device and possible amputation and VAD placement. I have learned from this patient that it is always important to treat the patient and not just all of the machines. Working in a cardiac ICU, it is hard sometimes to remember that we are still taking care of live human beings, not just adjusting our monitors, devices, and shooting our numbers. I will attempt to never lose that thought as I continue to care for this critically ill population. Okay, that was all of my assignment. I will post the references from the research articles that I used below the video. Again, I apologize for the late submission, and thank you all for your time.